Welcome everyone to a free webinar on critical time intervention hosted by C4 Innovations and the Center for the Advancement of CTI or CACTI. My name is Rachel Ely from C4 Innovations and I will be your moderator for today. Before we jump into the content, there are just a few housekeeping things I wanted to make sure everyone is aware of. So you are in listen only mode. This means that you are unable to unmute yourselves or share your camera, but we do hope that you will still continue to participate fully, as some of you already have using the chat box. If you want to send a message directly to the presenters and the hosts, please just make sure in the drop-down menu on your chat box, you select hosts and panelists, and that'll come directly to us. But we hope you'll also participate with each other and share ideas, resources, experiences in the chat box. So to make sure that you share what your thoughts with everyone, if you're open to doing so, in that same drop down, just select everyone. That should be the normal automatic setting. But please feel free, if you have any questions about tech support, just ask Marcia and Mia in the chat box. They are our wonderful tech support today and are here to help you. We will be pausing every once in a while throughout to answer questions. So please, if you have questions, you can ask them right into the chat box or in the Q&A, and we will be monitoring that for you, and we'll pause and let the presenters respond throughout. Lastly, before we just jump right in, this event is being recorded and will be up on C4's YouTube page and the CACTI website, I imagine, shortly after this live event. If you have any questions, concerns, want to discuss how we can support you, please email training@c4innovates.com. We'll be sharing some more contact information as we go forward and at the end of the webinar. So let's get right into it. We're going to start off today with a brief overview of CTI. We'll talk about some updates around the model, and then we'll talk through some training opportunities if you want to dive deeper into CTI in the model. So today you will hear from three presenters. First will be Dan Herman, the director of CACTI and a professor at the Silberman School of Social Work at Hunter College. Kimberly Livingstone, who is an assistant professor of social work at the Plymouth State University, and Rafina Lee, who is the associate director of CACTI and also a professor at the Silberman School of Social Work. And our first section today is an introduction to CTI, and we will get started. Dan, I'm going to pass it on to you, and let's go.
Okay. Thanks, Rachel. And thanks to all of you for taking some time out of your day to join us and learn about CTI. What I want to do is in 15 minutes or so, kind of give just a brief overview of what CTI is, sort of what the background and rationale for the approach, and describe the essential kind of elements of it. And I'll talk at the end just a little bit about how it's being applied in rapid rehousing in a relatively new context. So as Rachel said, this is just going to be like a very brief overview, hopefully answer some basic questions. But if you're interested in learning more about the model, I hope that you'll avail yourselves of a variety of different training opportunities that you might have from C4 or other trainers who work in CTI. So this picture is just to show you where CTI began, and it goes back well over 20 years in New York City, where I actually worked with some of the colleagues of mine who really developed the model originally in the shelter system. And so the way CTI developed was by social workers and other human service workers who were working in the New York City shelter system and some of the very large shelters that existed at that time. This particular shelter had close to 1,000 men sleeping on a drill floor in a National Guard armory. This is not something that still exists in New York, even though New York has a big homeless population and a big shelter system. But at that time, there was just these very large sort of institutional shelters had been set up sort of in a crisis mode. And what was going on here, among other things, was that there were outreach workers and who were working to identify people who needed extra help, people with medical and psychiatric problems who were in these shelters, and then trying to engage them, get them involved with services and treatment, some of which was delivered on site. And then over time, help people get stable, get entitlements, get access to housing, and move out of the shelter. And and what the experience of the team was here is that often what happened is that after people were able to move out of the shelter and move out of homelessness into a variety of different kinds of housing settings in the community, that unfortunately many people within not too long a period of time ended up homeless again or losing their housing. Next slide, Rachel. So what the team kind of realized was that even though people had been stabilized and given access or referrals to services that could help them and supports that could help them, this transition process often for many people led to this discontinuity in assistance and in support that they were receiving. And we were working at that time with many people who had a lot of, as I'm sure many of you are today, with multiple kinds of needs. They're going into communities where there are very few services or certainly not very well organized service systems. And that this kind of transition period, as well as the loss of connection with helping people in the shelter system, often led to a discontinuity in support during this transition. So the insight of the folks who were working in the shelter at this time was to try to figure out a way to help people during this transition process. Next slide. In a more thoughtful way, and a more well-organized way than simply giving people a discharge plan or sending people on with referrals for follow-on support. So CTI, critical time intervention, was developed to try to bridge this transition period with enhanced support to be provided during that period by CTI workers, whose job it was very explicitly to help people make those transitions more effectively. And this is why the name critical time intervention we came up with that name thinking that this transition period was a critical time, and that if we could be more helpful and more successful in providing time-limited support during this period, people could potentially have a better trajectory over the long haul. So the idea, next slide, the idea with critical time is that, with critical time intervention, is that if you can do things during a critical period, that they could have a long-term effect. So critical time intervention is a time-limited model that aims to help people, set people on a more positive trajectory over the long run. Now, obviously, I put this in the perspective of critical time as a risk period, or a period during which people are at risk of adverse outcomes. But also, we might want to think about critical times of transition as a period of opportunity, because a lot of times when people are in this transition period, they may be able to take on new, they may have more energy to try something new. Sometimes we can identify and help to resolve the kinds of barriers that may be holding them back. Sometimes people are open to establishing new connections with new sources of support in new places that they may live. And so I like to think about critical time, this critical time, as both a risk period, but also as a potential period, a period of opportunity during which new things can be worked out. So next slide. So the model is a case management approach that many of you maybe are probably familiar with case management, or sort of traditional case management. What differentiates it is really three things. One, as I've already alluded to, it's time limited. It's not an ongoing intervention. CTI, the original CTI model, is a 9-month model. There have been other adaptations of CTI in which it's used for a briefer period, 6 months, sometimes even briefer. It's highly focused. So CTI workers focus only on a small number of priority areas that, for that particular individual with whom they're working, places them at highest risk of a return to homelessness or other adverse outcome. So even though we're working with people who may have a broad range of needs and concerns, the CTI worker tries to hone in on just a handful of areas that are most critical for that, to help that the person be successful during this transition. And then finally, it's carried out in 3 phases, or in 4 phases actually. So CTI is a phased model, and in each of the phases, the CTI worker does somewhat different things, or focuses in somewhat different emphases. It's also carried out in terms of the degree of intensity of involvement between the worker and the client that reduces in a planful way over the course of the intervention. And the reason we do that is that the idea is that the effort is to slowly pass responsibility for connection and support off to other resources in the community, and not for the CTI worker to retain or maintain the role of being the primary helper for this person during the transition. So for that reason, we organize things so that they're in declining level of intensity of contact between the worker and the client over the phases. So as I said, CTI it takes place in 4 phases. One, before the beginning of the transition, which on this chart we're calling pre-CTI, and then 3 phases to follow. And I'll talk about sort of what happens, or ideally what occurs in each of these phases now. So in pre-CTI, this early engagement phase, the idea here is that ideally the worker and the client the worker is able to begin to establish a connection or some kind of relationship with the service recipient or client before the actual transition begins. Obviously, this whole thing is a transition process, but think of it as if we're working with people who are moving from shelter to housing. So this would take place before the actual move. Or if we're working with people who are being released from a psychiatric hospital, it would be before the discharge. So ideally, the worker is able to get in and meet that person, ideally face-to-face, 2 or 3 times, to begin this connection, so that then when the person is sort of out in the post-discharge or early transition period, the case manager already has some connection with the client to build on, to try to hopefully maximize their effectiveness, as their helping effectiveness. So phase one, this would be what would occur immediately after the person begins this transition, would be the most intensive level of contact between the worker and the client. The idea is that the worker is providing direct support here, both emotionally and instrumentally, like sometimes helping to meet needs, gaining a better understanding of the person's ongoing needs, and developing a plan for trying to address those needs by linking them with services and supports in the community. So just some of the things that the worker might be doing during this period would be obviously visiting this person in the new place where they're living. CTI is largely a community-based model. It's not a model where the CTI worker sits in an office and only works on the telephone. I mean, obviously during COVID period, we're dealing with other kinds of restrictions, but in normal times, this is much more of a face-to-face model. The CTI worker would be helping to mediate problems or relationship problems or problems with housing settings or other individuals who are in the sort of helping network. Sometimes the CTI worker will be directly introducing the client or the consumer to various providers that they might be connected with, and hopefully doing that in a very active way. So the idea here is to, in an active way, link people to the kinds of connections that they need. And that could be formal treatment services or programs, but it could also be what we would consider informal sources of support. So this could involve working with family members or other people in the community or people in the faith community who could potentially be supporters of the person. And that's the term that we use here. This caregiver term is sort of a broad term that we employ to sort of mean the wide range of people who could potentially be helpful. The other thing that goes on during this period is hopefully beginning the process of helping the client to build up their own skills and capacity to make use of services and supports. And in a very real-time way, the worker is able to see how well these connections and these linkages actually are operating, and see which are going to be worthwhile and which maybe aren't going to be, so that changes could be made or revisions could be made in the plan. Now, in the next phase, actually, before we go to the next phase, this is a good slide here. Go back. You can go back, Rachel. Yep. So I just wanted to, I use the term linking, and we emphasize a lot of that in CTI. I just want to make sure that we all are on the same wavelength with this. So what we mean when we talk about linking to services is something a little different from what often case managers end up doing, which is kind of referring people. So we really emphasize the need for the CTI worker to, in a very active way, make these connections and help these connections operate effectively. And when they're not operating effectively, to actively intervene to try to resolve conflicts or mediate problems, or sometimes have to make changes to these linkages. And the only way to do that is really by being very closely involved, by directly seeing how things are working. So that kind of goes all the way through CTI, but it's especially important in this early phase, this active linking model. In phase two, the CTI worker steps back and is trying to help the client take more responsibility for managing these supports. And hopefully the support system, or the linkages and services and supports that have been identified and put in place, are operating effectively. And so the CTI worker is taking a step back, being less directly involved, but still closely enough involved to monitor what's going on and to make modifications or adjustments when planned supports and linkages aren't working out. So that's the sort of, that's why close monitoring is required. So they know, so the worker knows what needs to be revised. So that's what we call troubleshooting. As I said, less frequent meetings between the worker and the client. But the worker should definitely be available to intervene when there's an important crisis or loss of support. And then in phase 3, this is the final phase of CTI, and it's a planned termination. So the idea here is in the last couple of months, the worker has stepped back, taken one further step back, is available to consult as needed, but is really looking, is planning to end the relationship. And as I should have pointed out at the beginning, it's very important to make clear both to the client and the potential members of the support system that the CTI worker's role is time limited from the very beginning, so that as we move toward phase 3, there's an expectation that the CTI worker, him or herself, is going to be stepping back, and the support network is going to be more in the role to take over. I alluded to the fact that CTI is highly focused in certain areas. It's important to keep in mind that these focus areas are going to be individualized, different for each person. And they may be different in different populations that you could be working with. So some populations that we might work with CTI in might tend to have more needs in the area of health or mental health treatment or substance abuse problems, whereas other populations that we encounter in CTI programs and within homeless services as well, might have a whole different range of kinds of needs that would focus more on family issues or legal concerns. Let's see, next. I think hopefully it's been clear, but I want to make very explicit some guiding values that we promote in the CTI model. As I've suggested already, it's highly individualized. So what the worker does and where the worker places their effort is going to be different depending on each client. It's client-centered because the priorities and needs of that client should draw from that person's own priorities. And so the plan should be something that of work should be jointly directed and jointly conceived between the service recipient and the worker. We have a recovery orientation in the sense that we believe and promote the idea that people can do better, and people's lives can become more stable, and people can move forward regardless of what's come before. And in terms of substance use issues, we promote a harm reduction approach because we feel that it's most likely to lead to effective engagement and outcomes in people who have substance misuse problems. Right, this is important. When people hear the term phased models, we tend to think of models where clients have to demonstrate a certain degree of readiness to move from phase 1 to phase 2 to phase 3. I mean, there are a lot of models like that. CTI is different. The phases of the model are basically fixed, and the program model dictates pretty much firmly when transitions are going to be made from phase 1 to phase 2 to phase 3, almost from a calendar. It's not focused on whether the client is ready to move. And so CTI's interventions, or the duration of a CTI intervention, is pretty much fixed from the beginning. There's some flexibility, obviously, in certain situations, but pretty much every CTI intervention should last as long as the model that's being employed there, typically 9 months or sometimes 6 months. It's a little counterintuitive. I don't have time to go into it today, but we certainly can. Our website has plenty of has many publications and plenty of research evidence that focus on the effectiveness of CTI. CTI has been widely studied and evaluated in rigorous randomized trials. And so we really do have pretty strong evidence of the impact of the model in a variety of different settings. So if you're interested in research, come to the site and you can check it out. Next. The other thing just to say is that I described how the model began in a homeless shelter system. Since that time, and I'm sure those of you who are human service or social service workers are probably thinking as you hear this, that there are a variety of different kinds of transitions or critical times that a model like this could potentially be relevant for. And in fact, that's the case. So over the years since we've been working with the model, the approach has spread to be used in a whole variety of different kinds of transitions with different populations, some more well-studied than others. So, and in fact, you'll hear a little later today, I think you'll hear about some of the work that's being done in New York and elsewhere where different populations are being served in CTI programs. I do want to say that regardless of whatever adaptations are made for different settings, different populations, these elements are what we consider to really be core to the model. So adaptations to CTI should all maintain or retain these elements, or else it's probably not going to look much like CTI. So, and I would say that the first one here, this transition period, is probably one of the most essential of the essential. In other words, CTI doesn't really make sense if it can't be applied in the context of a transition point. It's not meant to be a model to be used for ongoing support or ongoing services, ongoing case management. It's not a good fit for that. Yep, and we could go to any questions. I did just want to point out, maybe before we go to the questions, I did want to just let you know that we had or maybe you've got them after, Rachel. I did want to talk a little, so let's take the questions now. And then we can talk a little about rapid rehousing.
Any questions for Dan? Please feel free to type them in the chat box, type them in the Q&A. I also know that if you are formulating them and not quite ready, we'll give you a few minutes, but then we'll also have sort of a Q&A catch up later at the end. Yes, I can absolutely go back a slide. And this is being recorded, so you will be able to review this. It'll be on C4's YouTube page, YouTube channel in the next couple of days. So please feel free to take notes or screenshots, but no need to memorize it. I'll give a couple more minutes. And just one quick question that came up to me while you were speaking, Dan, was if you can very briefly talk about just how COVID changed CTI, or how that has had to change, or if it's been able to adapt to this ongoing pandemic.
Yeah, well, it's been obviously, it's like for all of us working in the field, it's required adaptation, and it's been a real challenge. I mean, as I said earlier, we strongly believe that this model really is the best fit for an approach in which workers are able to directly observe and clients' lives in the community. And to the degree that that's more challenging, with COVID restrictions, I think it's been difficult to work around. I mean, obviously, like all other, human service organizations, I think workers have had to rely much more on telephone work, FaceTime, other kind of video chat, both to communicate with clients as well as to service providers and potential linkages. I can't say that we have, unfortunately, I can't say that we have any systematic data or reports on what that's looked like. Maybe one of the other presenters will be able to speak to that.
Thanks, Dan. I'm not seeing any questions in the chat box. Let's see, one question came in, a few are coming in through the Q&A. So how effective do you think this model would be ran by a peer-run organization?
Great.
That's a really good question.
Yeah, great question. Thanks for asking that. We have some experience, a couple of specific pilots in which all the workers were peer workers or persons with lived experience. We think that should be, that makes a lot of sense. And I think that peer workers who are trained up in the model and would be great CTI workers. I mean, I think the pilots I'm familiar with were quite successful with it, and I think it's an ideal kind of opportunity for peer workers. I mean, like any other worker, and we didn't really talk about it, but in the training, one of the important elements of CTI is that there is the CTI workers are typically people who don't have professional level training. But that they do receive regular supervision, weekly supervision in their organizations, typically by a master's level, at least trained person. So I would say that would apply for peer workers as well as non-peer workers or any other kinds of workers.
Wonderful. And I see other questions coming in. I want to make sure we have space for our other presenters. Just one more, and then we'll move on and we'll catch up later. How would this model work with transition from inpatient psych hospitalization in a program that has 3 months or less to work with the client? And I know Rafina is going to be talking about some early episode psychosis or onset of psychosis. So I don't know, Dan, if we should save this or if you want to take it.
Well, maybe Rafina will give the talk about this first episode psychosis program, but I'll say that we have a lot of experience with CTI in working with people transitioning from inpatient psychiatric treatment. In fact, one of the earliest major randomized trials that I ran was exactly in that setting. So that's a common use of CTI, and obviously it's going to look different depending on the institutional setting that we're working in, length of stays in hospitals, that kind of thing. But we think it's a very good fit for that.
Great.
I just want to add that in terms of a 3-month intervention, we've had quite a few of those, but they have usually been with limited outcomes. They were aiming for, you really can't do a real CTI, a full CTI in 3 months, but you can have a limited, like we had one out of, there's ones where you're just trying to get people connected and that's it, to services in the community, to mental health services, but it doesn't do much more than that.
Thank you, Sally. A cameo from Sally Conover today. Yeah. Okay, well, I know, Dan, you wanted to talk a little bit about rapid rehousing, so please go forward.
Just real quick, because I just want to point people in the direction of information. I know that rapid rehousing is a program, a policy or program model that's been growing fast across the U.S. and probably operating or in your community. So to the degree that anyone is particularly interested in CTI, how CTI might work in rapid rehousing. And just for those of you who don't know what it is, it's essentially an approach that systems can use to try to very quickly get people into housing who are homeless without relying on shelter systems for long-term sheltering, with typically a time-limited rental subsidy to help them pay for their apartment or their house for a time-limited period, sometimes 6 months up to a year, and then access services and support. So the way CTI fits into this is, I think I might even have something on the next slide. The way CTI works in rapid rehousing is essentially to be a model for organizing the case management piece of rapid rehousing. So if rapid rehousing involves a housing subsidy, a rental subsidy, a time limit rental subsidy, plus case management support, CTI is a way to organize the case management piece. And we worked for several years with the National Alliance to End Homelessness, the Melville Charitable Trust, the state of Connecticut on a statewide project where we adapted CTI to be used in rapid rehousing programs. And there's a pretty extensive toolkit available through the National Alliance on their website here, with a replication plan, with manuals, with tools for how to learn about the model, and links to training resources who can train up providers and communities explicitly in how to use CTI in the rapid rehousing context. So I would point you in that direction if you're especially interested in, in learning more about CTI rapid rehousing. And then finally, this is the website I think I alluded to. I think it's in your some of the materials that you've already seen. That is our website of CACTI, Center for Advancement of CTI. Yep, there it is in chat. Plenty of links here to resources, reports, research, newsletters, and you can sign up and get on our mailing list. That we won't overwhelm you with emails, but occasionally we'll send out emails. So that's it.
Perfect. Well, I am going to move us forward. Again, please continue to type your questions in. We are monitoring that, and we'll pose them later. And now I'm going to hand it over to Kim Livingstone. And we're going to give this remote control a try, and go for it, Kim.
Great. Okay. It worked. Okay. Hi, guys. I'm Kim Livingstone. I am an assistant professor and the new social work program director at Plymouth State University. PSU is one of the public universities that's a part of the University System of New Hampshire. And I'm going to hopefully be able to get back a couple slides. And share a little bit about what's happening with CTI here in New Hampshire. I do want to say that I think that the information that I have to share will likely be most helpful to those of you who are looking to implement CTI, either like currently or in the near future, or those of you who are just interested in what's happening here in New Hampshire. Okay, so the first thing I want to talk about is the CTI New Hampshire pilot initiatives. So back in 2017, and I should mention this, I moved to New Hampshire from New York City, where I was a doctoral student at Hunter, and I was working with Dan, Sally, and all those at CACTI, Rafina. And so I had a chance to work with folks closely at CACTI since 2013. So in 2017, which was just an exciting alignment of the stars. New Hampshire decided to implement CTI as part of their Medicaid expansion waiver. And so through this initiative, regions or integrated delivery networks within New Hampshire were able to pilot CTI in their communities using various implementation strategies. So CTI was rolled out in 5 of the 7 regions. And those pilots were addressing different transitions and different populations. Sorry, I'm supposed to be able to remotely change my own slide, but it's not showing up, Rachel. There we go. So this slide, this map identifies the 7 integrated delivery networks and some of the details about the CTI programs that were developed in 5 of those regions. As you can see, not every region identified CTI as one of their pilot initiatives, but we did have coverage in 5 of the 7 regions. And as you can also see that those details, they varied from region to region, which was great as part of the pilot initiative. We had CTI programs that were housed within community partners. We had one CTI program within a government office with the county. We had CTI programs that utilized a partnership among providers. So it was housed in one, but closely aligned with the work of another. They varied in target populations and transitions. So most of the programs actually focused on one transition. But as you can see that those were different within the different regions. One region in particular started with one transition, and then they actually expanded their referral criteria to include other transitions. So their one team covered multiple transitions. And then one note that I wanted to make was in Region 7. So Region 7, if you're familiar with New Hampshire, this won't be surprising to you, but it's Coos County. It's our most expansive, it covered Coos County, our most expansive and rural region. And this integrated delivery network actually opted to use a proposal process for their implementation. And so they sent out a proposal to different community providers. So they were able to implement 3 different CTI programs across the region, which seemed to be a good fit given the expansive geographic area that they were trying to cover. We had one in a homeless shelter helping people transition from homelessness to housing. Another program was developed within a correctional facility within Coos County. And then there was a third that was developed to assist system-involved families that were dealing with a vital service transition. Okay. So there were certain factors that facilitated and or challenged implementation of CTI in New Hampshire. And this is based on my own participation in that process and kind of what I've heard from the folks that I was helping over the past 3 years. These factors were both on the team and within the structure. So on the team, we know that stable and consistent support is super helpful. And really that's at 3 different levels. So from leadership, from peers, right? So others who are also implementing the model, or from those that are on your team, and then having those connections among teams. On the other hand, it was challenging when there wasn't consistent support from leadership or from peers, like if there were turnover, it was turnover on the team. And then also within the fit within the agency, it's an important consideration. So some teams fit seamlessly alongside other transitional services, or CTI practices were well aligned with the agency's existing mission. And this is not foreign from others who have implemented CTI. This is something we talk about in trainings, that it's challenging if there isn't a great fit, right? So there are some teams that were challenged if they were not a good match. So for example, if CTI core principles aren't a match with the beliefs or the practices of the leadership within the agency, then it becomes difficult to then implement CTI to full fidelity. So there were certain factors that were also facilitators or challenges within the structure. And we heard from Dan about the flexibility that's used in, providing services within the model. We know that it's more intensive work at the beginning, and then we slowly step back and hand off, work to either the individual or to the supports within the community. So the ability to do that work that varies in intensity, and also to do community-based work. So to be able to have flexibility around the location of work is important to the success of implementation. During implementation, CTI workers often reflected about the magic of CTI and what makes it work, right? One of the factors that we often discussed was the ability to really do the work that needed to be done, right? So that it wasn't like it didn't surprise anybody. It was just that workers were able to spend the time building rapport with clients, building community connections with supports, with clients in their communities, with their client supports. They often talked about the gift of being able to walk the walk, and to do what we know needs to be done to help people that we serve. Another factor is the fit of the CTI program within the system of care. So CTI is a model that helps people transitioning within a system of care. At times, CTI workers described that others perceived them as miracle workers, which I think is fabulous because many CTI workers are miracle workers. CTI teams got a lot of referrals that no one else really knew what to do with. And so it's important to note that CTI really doesn't solve existing problems within systems of care. It doesn't produce or create new services, but it really relies on linking individuals to services that already exist. All right. And then providing sources for implementation and fidelity support. That was my role, and I'll talk a little bit about that a little bit later. All right, so moving on, a few lessons that we have to carry forward from the pilot initiatives, and I won't touch on all of these given our interest in time, but I'd be happy to connect with anybody that wants to know more details. I did mention our rural region in New Hampshire, one of them, and it's important to note that rural regions may need different program structures, right? So it might be important to consider needs given the travel time, right, to get to in-person work or cell and internet coverage or other factors that might be important to rural areas. I talked a lot about flexibility already. So that's just something that is really important to the success of the implementation. Behind the scenes work is super important. Again, being able to walk the walk. So I will talk a little bit about referral sources. That referral sources may need regular upkeep, as do our connections with these other community supports that we're working with closely to meet the needs of our clients. And so some of the things that CTI workers or people on the team did was that they actually had what they would know as like their rounds. So they would, if they were working with people who were transitioning from a hospital, they would often they would have a day or a couple days a week where they would go to the social work department within the hospital and touch base face to face. Right. They also made great efforts to do regular informational meetings with community support so that people in the community knew what CTI was and what it wasn't, and what we could do for people and what we couldn't do. And then lastly, and maybe I'll talk a little bit more about this in a couple slides, but implementation supports may change over time. So much like the model is more intensive at the beginning, implementation support tends to be more intensive at the beginning. It's helpful to have like one-on-one coaching support, more intensive in the beginning. And in New Hampshire, we had the chance to also have a community of practice. And so I was able to really help programs make connections to each other. And then they were able to help each other as time moved on, which was really cool to see and help to facilitate. Okay. Let's Let's see if I can advance the slide one. Sorry, Rachel. There. Okay. So following an audit of New Hampshire DHHS in 2001, a statewide CTI rollout was recommended. And so while the rollout is planned to be more expansive to cover the entire state, as of right now, the focus looks to be on one transition and population. So they plan to have CTI programs available to help people transition from inpatient hospitalization to the community, specifically for those people with severe and persistent mental illnesses who are transitioning from psychiatric hospitalization. So as of right now, a CTI statewide director has been hired at the New Hampshire DHHS, and they are deep in the planning of this rollout. So while there isn't a lot of information yet available about the rollout and the specifics about that, it is pretty clear about how the circumstances leading to this initiative. So New Hampshire, and if we have folks on the call from New Hampshire, you know this, has one state-operated inpatient psychiatric hospital. They admit 1,200 people annually. So we know from data that was collected for this audit, and I have access to the report if anybody's interested in seeing it. I can provide a link to it. 21% of those folks who are discharged from that psychiatric hospital are likely to be readmitted. And despite substantial efforts, a significant cohort of people that are stepping down from the hospital are doing so without this optimal transitional care. We also know from this audit data that was done by A&M, Alvarez and Marzal, that many of these individuals were not eligible for ACT. So the thought is that they may instead benefit from a less rigid and restrictive step-down program that improves their health outcomes, keeping them ultimately from readmitting to the hospital. So CTI is a cost-effective and flexible model that can potentially complement something like ACT services. And that's because ACT is a community-based alternative to hospitalization, whereas CTI is a model that helps people transitioning out of hospital. So really, CTI could help to connect someone to ACT services if that were called for. All right, and then lastly, I just wanted to note my role in the initiative, the pilot initiative in the last 3 years, and then what the plans and what we hope will happen with this statewide rollout. These are some of the important factors in implementation support. So there are 4 components here. There's the professional development. So we planned and facilitated, and many people on this call were vital in doing that in the rollout. So we had professional development sessions that were timed based on the rollout. And those were the 3 main professional development sessions that we offered. Implementation support and coaching. So we had region-specific individualized coaching available. I was the one who was able to do that here in New Hampshire. And so that seemed to be super helpful, especially at the very beginning of the implementation. And then another main component was the community of practice. So the community of practice was open to anybody practicing CTI in New Hampshire. So CTI workers, the clinicians, the leads of the teams. And we met once monthly. We did do quarterly in-person meetings as long as we could until COVID happened. But it really became a place of support and community for those who were involved in implementing CTI. And they really did lean on each other to help answer questions. And as the statewide facilitator, I was able to help make connections, because we know that when you're doing the work, when you're boots on the ground, you're not necessarily aware of what's happening in the region next to you, but it became super helpful for people to be able to seek out the support of their peers who were also implementing CTI when they ran into what we knew as the common issues in New Hampshire. If you had a problem, it usually wasn't just you alone. Other people in other areas were also facing it. So that was an important role that I had to kind of help facilitate that community of practice. I know that, CACTI is available to help make connections with other folks, maybe on the national level, because we become aware of, different issues and different ways that CTI has been implemented across really the US and internationally. And then lastly, fidelity monitoring and evaluation. That's the fourth component. We did do a fidelity train the trainer in New Hampshire. This is one of our lessons to carry forward, is that fidelity monitoring and the actual fidelity evaluation is labor intensive, and it is super helpful to have resources put in place ahead of time, because it's a lot and kind of not realistic for folks who are doing the work of CTI to also be responsible for the fidelity piece. So it can be important to make those connections with someone outside of that actual work. And that's about it. So I would be glad to take questions now, or if y'all have questions and want to connect somewhere offline, I'd be happy to do that as well.
Thank you, Kim. I see that Whitney would be interested in the link to that full report. So if you have it, plop it in there, and give a couple minutes for questions. It is, I agree with you, Bibi. It is really interesting to see how it goes in a state and hear that process. So I think that's really helpful from an on the ground, boots on the ground, as you said, Kim, standpoint for folks. Well, in the interest of time, I'm going to move us forward, but please keep typing your questions in as they come, and we will catch up to them at the end. So next, I'm going to pass it off to Rafina, and we're going to try this remote control once again, and take it away, Rafina.
Okay, great. Thanks so much, Rachel. Hi, everybody. My name is Rafina Lee, and I'm at the Silverman School of Social Work at Hunter College in New York City. And today I'm going to talk to you about an adaptation of CTI for young people with recent onset of psychotic symptoms. So, let's see. Here we go. So I'm going to just kind of do a quick overview of schizophrenia, because the adaptation that I'm going to speak to you about today really does have a very narrow focus on young people with recent onset of what seems to be likely schizophrenia spectrum disorders. And the second part is to provide a rationale and evidence for why it's really important to pay attention to these young people. That we really want to actually reduce their, what we call their duration of untreated psychosis, and also to provide early intervention or specialized services for psychosis. This second piece, this rationale and evidence, it's a little different. So in many ways, what Dan and Kim have been talking about is this idea of like this, that there are these critical times of transition, right? Today I'll talk about this critical time of transition as well to a certain degree, because this adaptation focuses then on young people who've been hospitalized for the first time ever. But I also want to encourage you to kind of think about, hey, it's even separate from transition, that when we think about young people who've recently started experiencing psychotic symptoms, that this is just overall a really, really important critical time when intervention can be especially effective. Okay, so like not just on transition, but kind of like conceptualizing when can CTI be really helpful at other critical times. And then I'm going to talk about the actual implementation, which is has to do with the New York City Department of Health and Mental Hygiene and their development and implementation of what they call the New York City START team, which is their supportive transition and recovery team. Okay, so the big picture actually, is that schizophrenia, which is traditionally considered a major mental illness, right? We know that the prevalence is about 1% overall throughout the world. Here I'm really going to note the incidence, which is about 15 people per 100,000. So by annual incidence, I'm saying people in the last year who've newly developed psychosis or what seems to be schizophrenia spectrum disorders. And you can see it's a pretty small number, right? And I'm really interested in incidence because I'm really interested in people who have newly kind of developed schizophrenia spectrum disorders, right? And we see that men are about 40 to 60% more likely than women to develop schizophrenia. It usually develops in young people, and in general, men younger than women. And I'm going to remind you that I said, hey, the prevalence is, about 1% worldwide, and yet we can see, like in the next 4 bullet points, that it is a very significant, that there's just really very significant personal and societal costs associated with this diagnosis. Okay, so basically, this is in this slide, what I'm really trying to kind of argue for is that there is a new way, a relatively new way. I mean, it's probably about 10, 15 years old at this point. It started internationally. Actually, it's more than 15 years, probably like 20 years old at this point. It started international. A lot of the research is international, but it's also here in the US, where we are very much trying to think about schizophrenia in a different way. That the way that we used to think about it was once people started developing psychosis, that there would be this deterioration, that it's a progressive illness, and that everybody was going to become chronically ill and be disabled. And really what we're trying to do is make this argument that actually that this time around here, right around the onset of frank psychosis, that it is a really particularly important time for prevention, so that people do not get to this chronic residual end stage, right? So one of the things that I really want to kind of like focus in on is that, so this is actually a systematic review of the duration of untreated psychosis, and then outcomes, and all these different kinds of outcomes, whether it be in positive symptoms and negative symptoms and quality of life and social functioning and occupational functioning, etc. But there's this really strong evidence base that indicates that the longer it takes a young person to get to treatment for schizophrenia or for schizophrenia spectrum disorder, the worse their outcomes are across many different domains, and over a span of at least the 24 months that these studies reviewed, right? And this is actually a slide that I just kind of wanted to point out from some really important research that was done here in the United States. So basically, I'm sorry, it's a really super busy slide, but basically there was a randomized trial, controlled trial of something called the Navigate intervention that recruited young people with recent onset of psychosis throughout the United States. And about half the people got treatment as usual, and the other half of the people got this experimental coordinated specialty care specialized for young people with recent onset of psychosis called Navigate. That was the name of the intervention. And what they found was that these 2 green lines here, right, one dotted and one straight, these are the people who got treatment as usual. And what they found was, hey, people actually did do better over a span of 2 years, but their duration of untreated psychosis, whether or not they took a really long time to get to treatment or if they took a short time to get to treatment, they actually did about the same. So that like duration of untreated psychosis wasn't that important. And they improved, but not that, they improved actually pretty significantly, but not as much as these people. So these people, I guess one of the things I really want to flag about this is that this is the line for people who got the special treatment. This is the line for the people who got the Navigate treatment, who also got the treatment really quickly. Okay, they had the biggest gains by far. And one of the things that also came through from this research is that there were young people who got the special intervention, but their duration of untreated psychosis was really quite long. It was more than the median. It was more than 74 weeks. And actually, they didn't do much better. They look actually very similar to people who got treatment as usual. So what this research here in the United States did was it kind of it reinforced a lot of the international research that seemed to indicate that really for people to do the best, right? That we really wanted people not only to get that specialized treatment, but to get to treatment as quickly as possible. And this is where actually CTI becomes really so important in terms of trying to get people to treatment as quickly as possible. So this is some work that Michael Compton and Beth Broussard had done about to kind of speak to like what the current system looks like in the United States, so that we could see this young person here, right, starting to experience psychosis. And it takes them a really long time. It's not a straight line to help seeking, that they, for a variety of different reasons, might not say, hey, something's going on. And then from help seeking, saying, hey, I think something's wrong or I need help, to get to some kind of outpatient mental health treatment, that we see this, all these kind of jagged lines where police is often involved, an emergency room stay and an inpatient stay is also often involved before people can get to some kind of outpatient treatment. And even then, after the outpatient treatment, like people may connect to outpatient treatment, that we see a lot of dropout from care where people really don't like the services, or we see long-term dependence, so that people kind of stay in the system and become, quote, professional patients, right? Are kind of told explicitly, hey, not to kind of really to try to keep stress low and not to really actively engage in work or school, etc. So this is actually just something I wanted to flag in case you weren't aware. I remember reading this and really just being surprised at how long duration of untreated psychosis in the United States is. So that the average was about 196 weeks. So that took people, close to, I guess, almost 4 years. The average was about 4 years before people actually got to treatment, right? The median, which is at 50% below, 50% above, was about 74 weeks. But that also that almost 70% had a duration of untreated psychosis that was greater than 6 months. So like, if you think about it, this way of thinking, here's a young person experiencing frank psychosis, and it takes them, about 50%, about almost 70% had, it took them more than 6 months to actually get to some kind of treatment. And once again, kind of reminding people that the quicker you get to treatment, the better your outcomes are going to be, right? The quicker you get to treatment, and also the kind of treatment that you get afterwards. So the vision really is, to get people to help seeking quicker, and then from help seeking to ideally avoid an emergency room stay, an inpatient stay, the police, et cetera, and to get them to actually this specialized early intervention services to coordinated specialty care. Okay, so just kind of like in the larger context, to kind of think about like just kind of what a critical, the recent onset of psychotic symptoms is a very critical time, right? And so basically what the New York City Department of Health and Mental Hygiene did was they decided that in the context of all this international research and also the research that was coming out of the US, that they really wanted to focus in on these young people with recent onset of psychosis, and to actually connect them to care as quickly as possible, okay? So they actually made changes in their public health code, where they added admission with a first episode of psychosis to the over 90 health-related diseases, conditions, and events reportable to the Department of Health. So basically, there was this reporting mechanism that if a young person was hospitalized for the first time ever due to psychosis in New York City, that this reporting mechanism would kick in, okay? So basically, it would be anybody between the ages of 16 to 30 who's a resident of New York City, who was admitted to New York City hospitals with psychosis diagnosis for the first time ever. These were the kind of different diagnoses that were eligible, and that all New York City hospitals must report admission of these individuals. within 24 hours of admission. Okay, so what the Department of Health and Mental Hygiene was trying to say was, we know that there's an effective intervention out there. And meanwhile, simultaneously, what New York State was doing was building a lot of these specialized early intervention teams. In New York State, it's called On Track New York, but all throughout the US, there's been a lot of buildup of coordinated specialty care in general. And so what we're really seeing is like this public health initiative to try to get to identify young people with recent onset, and then to try to get them to the care that would most provide the potential best outcomes as quickly as possible. Okay, and in order to do that, what they did was the New York City START team used the CTI model. Okay, so once again, a care coordination model, not a treatment model, right? And that really the purpose was to actually get people to the correct care or the best care as quickly as possible. This was a 3-month intervention. And one of the things I do want to flag here is that maybe a little different than other CTI adaptations is that the New York City START model very much focused on having master's level trained CTI workers. And there were several important reasons to do that, but the 2 pieces that I just really wanted to flag, which are particularly relevant here, is that young people with recent onset of psychosis are at very, very high risk of attempting suicide or non-intentional self-harm. And so it was very important for the CTI team to be able to do very strong assessments around safety and intervention about safety conceivably. So that was one piece that was particularly important, and why there was a focus on these master's trained social workers or other master's level trained clinicians. And then the second piece actually had to do with really trying to kind of come up with being able to do really good differential diagnosis. That what we often might see in community-based settings is like a diagnosis that might kind of fit for that time, but we also know that psychosis happens in the context of so many other for so many other reasons. It could be, you know, substance related, it could be mood disorder related, etc. And really, this model focuses on the schizophrenia spectrum disorders. And so it was really important that the CTI workers were able to do a good differential diagnosis process in order to make the referrals to the correct programs. Okay. I think that's pretty much it. I guess this model has been around for about 4 or 5 years. There was actually an article published about, I'd say 3 years ago in Psychiatric Services that kind of gave an update about how this model worked and how there were actually really high rates of uptake, that all these young people who had been hospitalized for the first time ever did accept CTI services and ended up sticking with the service and going on to coordinated specialty care or other specialized early intervention services. And I can put a link for that article in the chat box as well. Okay. That's
Wonderful.
it.
Thank you, Rafina. What questions do folks have for Rafina about what she just presented to us on? I'll also say that if you have questions that didn't get addressed from the previous presentations, please feel free to ask those as well. We do have a little bit of space here for some Q&A. And just quickly, while folks are typing in questions and formulating them, I will just let you know of a training opportunity by BB Smith, who is here, not in her video, but she has been very active in the chat box, and we're grateful for that. BB Smith will be training through C4 on a course which will go over the CTI model, dive more in depth, talk about implementation. It'll run for 1.5 hours a week for 5 consecutive weeks. It is Zoom based, much like this. And it starts September 13th and runs through October 18th. If you have any more questions, please feel free to reach out to C4 Innovations, and our wonderful tech support team just put a link to learn more about the course in the chat box. So please feel free to do that as well. It's a great opportunity to just dive in and learn a little bit more about the model, what Dan went over briefly, and then think about how it can be supportive to your organization or your program and your population specifically. So any questions? This is your time. And I'll give some space for people to type those in. To our presenters today, are there common questions that you guys have gotten that typically come up? I know questions are always asked about clinical supervision, the staffing patterns, things like that. I know we don't have time to dive into all this. The course with BB will. But what are some typical questions you guys get that we can answer while we have some space?
Well, should I type it in or should I say?
Go for it, Dan.
Well, one thing I was going to say is that staffing is, I'm glad you mentioned that, because the one thing that's important, and I'm sure that you all on the call who are experienced in the field, based on what we've described, you've probably already figured out that to do this work effectively, you would really need, you could not do it in the kind of a setup where case managers could not deliver CTI if they have a caseload of 75 clients. You know, this is meant to be delivered in a context where workers are going to have an average limited, probably up to like 20 clients at a time. And ideally, their caseload should be distributed evenly through the course of different phases of the model, because as we've discussed, early phase work in CTI is much more intensive than later on in the intervention. So while a worker could handle 20 clients, perhaps on a caseload, they couldn't handle 20 or 15 clients or 10 clients even who are in phase 1 of the intervention. So that's, I think, so when you think through whether CTI could work, is a good fit for the context that you work in, you have to think about whether the resources are there to permit a program to operate with that size caseload. So I think that's a really important thing in terms of feasibility or of implementation in your system or your program.
Yeah, and a question did come in sort of around staffing related to that. To what extent is client choice part of this model? If there are more than one staff person in the CTI, a CTI worker, can the client choose? If they can't, how do you handle problems that arise between the client and initial case manager? That's a really good question. I imagine that comes up.
Yeah.
Any responses to that?
Kim, you want to respond to that, or whether you saw that as an issue in with the programs you worked in most recently in your state?
Yeah, sure, Dan. So yeah, I would say client choice is a huge part of the model and the work that's done. I think that there is often, if when possible, we go with the, client's choice full out. They say, I want to work on this goal, and that's the goal that we're working on. At times when it's needed, CTI workers can employ like motivational interviewing. Another thing that I always talk about when we talk about building rapport with clients is that you want to spend time building rapport with folks early on and often, because there are times where you're going to have difficult conversations, where you might have to talk about this discrepancy in, what they're identifying versus what you might have identified as a CTI worker. And so I think that we would suggest that you have that conversation, but it would be a difficult conversation to have. So you would want to be able to lean on that rapport that you've spent all that time building. And then bringing in those techniques from the toolbox of like motivational interviewing, harm reduction, like these things that are good complementary practices with CTI.
Thank you, Kim.
Yeah.
The only piece that I would actually add is, I mean, it's not necessarily like a part of the model per se, but I like Leslie kind of going back to what you were saying, which is like you could, like, there is a way to kind of implement client choice from the get-go, right? To say, hey, here are some options, right? What do you think would work best for you? And that's kind of like a way to kind of like present choice from the very beginning. It's not, a necessarily like a codified part of the model, but there's nothing that contraindicates that by any stretch of the imagination. And then once the intervention starts and there is an assigned CTI worker, it kind of like thinking about that, using the framework that Kim was talking about.
Mm-hmm. This is an unrelated question or statement, but just something maybe that we didn't, that often comes up as a question that we didn't really speak to today, but that, if the main thrust of CTI, as we've said, is rather than to serve the role directly as primary supporter or service provider, but rather to help the client connect with existing services and supports in their community, that often the question arises, well, what about, in where I work, there are just very few resources available. Like in some places, there's a lot more, like the service delivery system is much more robust, like a place like New York City, for instance. But in some other places, like perhaps, was that Region 7 in New Hampshire, the extremely rural area where the formal services may be few and far between. So the question comes up, well, how does CTI look in a setting like that? And I think that we have to acknowledge that the way that the model is going to operate is going to be quite different depending on different contexts, and there's going to be a lot more the work in those settings. I think what we've seen is that workers need to be well, first of all, they need to be able to spend much more time traveling just to get at people, but also in terms of the availability of services, they need to be much more creative to try to rely on perhaps more in the way of what we would call informal supports and informal services, and more creative ways to try to help people address their needs that may not be as easily identified within the formal treatment system. So that's just a real life fact about, you know, the way that CTI works or would look in different contexts.
And I know, as you mentioned, formal and informal supports. And I'm wondering, oh, we do have a question, but I'm wondering if someone wants or wants to type into the chat box when the presenters, what an example of a formal support is and what an example of an informal support is. Because I know when I first started learning about the model, I couldn't always understand what was the difference. But it looks like, Leslie, thank you for another question. So thinking from like an HMO model, long-term relationships with a primary care physician, and you know, you get to change, and you know, as you wish, but with urgent or emergency rooms, you really got to take anyone who's there at that moment to get seen. So, you know, sort of thinking about the CTI worker, is the CTI worker more like urgent care or a primary care provider? I'm not sure if you guys like to answer, or it'll depend on the program.
Maybe they're more like a triage nurse. I don't know, like helping to make connections to those who can assist with the issues at hand. I don't know. Yeah.
The long-term relationships that the CTI worker sets up are in this example, the primary care. I think that, does that make sense? That seems like a,
you know what, to me, like what this question more highlights isn't like, you know, whether or not like it's like they're the emergency worker or whatever. It's more kind of like I think what this highlights really is that like it's really, really important on the front end to actually try to figure out like, hey, what is the critical time, right? Is it a time of transition from a shelter to a hospital to a housing, from the hospital? Because like by specifying that critical time and that transition, then you can kind of anticipate what might happen. So Leslie, in some ways I would say like, hey, maybe what you're talking about is like the critical time is actually if you were in the hospital for surgery and you're coming out and you're supposed to go see a PCP, right? But you don't know where they are. You have 6 to choose from. You meet one and you don't like them, right? And so then you stop going. What the CTI worker would do is say, hey, here's this critical time of when you've been discharged from the hospital, where primary care actually would be super, super important to like, so that you have better outcomes and you heal well, right? Let's try to figure out what your best option is for a PCP. And if something goes wrong with the PCP or like somehow or another, they're not really doing it right, and you know, the CTI worker is in place kind of help support you to try to figure out like, do I stay with this PCP? Do I go to a different PCP? Etc.
Thank you. And I got wrapped up in the conversation, but we are at time. So if you have any questions, you can contact both CACTI and C4 via email, our website. We're also both organizations on social media. Please feel free to reach out to either of us. Again, the criticaltime.org website has tons of information about the model, and C4 and others provide training on CTI as well as training on other recovery-oriented, person-centered and trauma-informed services. So we hope you enjoyed today's presentation. Please thank you for your participation, and please have a great rest of your day. Thank you, everyone. And thank you. Special thanks to Kim, Rafina, and Dan.
Thank you.
And our tech support, Marcia and Mia. Thank you all. Have a great day.
Thank you.
Bye.
Bye.